Hello, I'm Professor Jacob Bornstein. I will be moderating today's session together with Professor Mario Preti. Welcome. I will start by presenting my co-chair, Professor Mario Preti. Professor Preti is Associate Professor, a gynecologist and oncologist at the Department of Surgical Sciences. He co-chairs the Lower Female Genital Tract Unit at the University of Torino. Professor Preti is a past president of the International Society for the Study of Vulvovaginal Disease, ISSVD, and is currently the co-chair of the ISSVD Terminology Committee. One of his main interests is the precancerous conditions of the lower genital tract. Mario?
Well, thank you, dear professor. Thank you, Jacob, and a pleasure to introduce you. Professor Jacob Bornstein is a former chairman at the Department of Obstetrics and Gynecology at the Galilee Medical Center and the Bar Ilan University in Israel. His career included a term as president of the International Society for the Study of Vulvovaginal Disease, the ISSVD, and Professor Bornstein is renowned for his leadership in chairing the terminology committees of both the ISSVD and the International Federation for the Cervical Pathology and Colposcopy. He is the author of a recent book, Vulvar Disease Breaking the Myth, a comprehensive textbook in the field. Additionally, Professor Bornstein holds the position of editor-in-chief of our journal, the Journal of Lower Genital Tract Disease. Please, Jacob.
Thank you very much, Mario. Thank you for this introduction. And thank you all for joining us today for our virtual coffee with the experts. Together with Professor Preti and three expert panelists, we will discuss today the many challenges and issues we face when diagnosing and treating precancerous diseases of the vulva and vagina. Before we get started, I would like to invite you to join the ISSVD if you are not already a member. Be sure to visit our website. As a member, you have the opportunity to network with vulvar experts. We have an active email listserv where you can get immediate answer to your practice question. Additionally, we have frequent live online events like this one, as well as a resource library and an online learning website. Our World Congress and International Vulvovaginal Disease Update will take place in less than a year in September of next year in Ljubljana, Slovenia, in September. Registration and abstract submissions are already open. Mario?
Well, without further delay, let me introduce today's panelist, very high-level webinar. And first of all, our Gerda Trutnovsky, Professor Trutnovsky, is a deputy head of the Department of Gynecology, Medical University of Graz, Austria, and she has a special interest in vulvar disease and was the principal investigator of the randomized trial about the primary therapy with amiquimod versus surgery for treatment of VIN. Very important paper was published in Lancet last year. The second, also from Austria, is our friend, Professor Elmar Joura. And Professor Joura, here are you, dear Elmar, is a gynecology oncologist, associate professor of gynecology and obstetrics at the Medical University of Vienna, head of the colposcopy and vulvar services at the Medical University and Comprehensive Cancer Center, Vienna, involved in HPV vaccine trials since 20 and more years. We can type of PubMed, Medline, Elmar Joura, and a lot of paper, Lancet paper, British Medical Journal. We are so proud to have here you, dear Elmar. And finally, the youngest of the group is Dr. Eleonora Preti. We are not relatives, all the same surname, and Eleonora is deputy director. It's a very important institution is the Preventive Gynecology Unit at the European Institute of Oncology of Milan, Italy. Well, I think, dear Jacob, that we can start.
Oh, yeah, Mario, before we turn into our panelists and hear what they have to say, what we did today, we received quite a few questions by mail. So we would like to maybe answer them. And let me talk to you first. So one of the participants sent us a letter. This is not in English. I think it's in Italian, right? Algoritmo
Spanish.
diagnóstico or Spanish del VIN diferenciado. Is there a special diagnostic algorithm for differentiated VIN?
Well, I think that the question is very important, but most of all, we have to keep in mind that before the histological diagnosis, we need to biopsy the lesion and to send the specimen to the pathologist. And so it's important to recognize the lesion, first of all. So it's not so easy to recognize a differentiated VIN in a field of lichen sclerosus. And sometimes it's a hyperkeratotic area in the field of lichen sclerosus. Some in other cases, it can be not very easy to identify. When we have a biopsy, I suggest to collaborate with our pathologist and send him our thought about the suspicions of differentiated VIN. And so, first of all, the most important is to use, in case of doubts, immunohistochemistry. So the first part of the algorithm could be to use P16 if positive or negative. And then we can stratify the immunohistochemistry using the P53. So both the P16 negative and the P53 positivity can help us in differential diagnosis with HPV-related intraepithelial neoplasia. But we have to keep in mind that P53 is not too easy to interpret because we have basal sparing, wild type, absent of null expression. So we need really pathologists dedicated to vulvar diagnosis. So we can have the best between gynecologists, pathologists, and also dermatology. You know, dear Jacob, that we learn so much from our friend dermatology in this society.
Would you say, well, we're talking about a differentiated VIN, and we all know that differentiated VIN is HPV independent and it has a more malignant potential. And when you talk about VIN, you always talk about lichen sclerosus. So here is another question by our participants, the association between lichen sclerosus and VIN and the treatment of with high-potent steroids in cases where you treated VIN and there's still a lichen sclerosus.
Yeah, we have to continue corticosteroid therapy after DVIN excision. And we know up to now, until more trials are going and present the result, that surgical excision of differentiated VIN is needed because we cannot leave a positive margin, as the differentiated VIN is a high, as you told us, a high malignant potential. And so we have not to live inside to differentiated cell that within a couple of years have the risk of invasion, is the highest potential risk of invasion. And of course, the highest risk patient are patients who do not apply correctly the corticosteroid therapy. So we need to follow them almost twice a year. So we can better understand the course of the lichen sclerosus and promptly diagnose other differentiated VIN, because we know that once the patient has one differentiated VIN, she is at risk for the subsequent year to develop other lesion, not HPV related, so more a higher risk to progression within the first 2 years.
By the way, my only patients who developed vulvar cancer after years of treatment of lichen sclerosus were those who had continuing symptoms. They had an itch, a very, very strong itch. Is that true? And here is another question by one of the participants. Do continuing symptoms and progression of adhesions indicate a higher risk for vulvar cancer with lichen sclerosus?
It can be. We have the paper of almost 50 years ago from the Australian school, the itch and scratch syndrome, and probably pruritus is our way to understand that something is wrong in that part of the vulva and an oxidative damage is going on. And so we have to better follow this patient, because probably we have not so many studies about symptomatology, because usually are long-standing symptom for this patient, but we need to follow better the not respondent patient, both for symptomatology, both for the lichen sclerosus. So it's important.
And last question to you before we start engaging our panelists. And here is a question. How do you treat DVIN in a 90-year-old woman?
Oh, so happy for her to have 90 years, but the way is the same at 50 years, taking in mind that the older the patient, the higher the risk to develop cancer. So we need to excite the lesion, and so we can have the 100-year birthday with this patient without problem.
Okay, Mario, I'll let you lead now the conversation.
Well, and the first question are to you, Eleonora, and our question in Spanish. I can read them in Spanish or in Italian or in English, translation. The histological difference between el VIN differenziato, the differentiated VIN, and the usual type, the HPV-related VIN, Eleonora.
Thank you, Mario. This is a real difficult question, because I think that this topic, it's a challenge for pathologists, and I'm not a pathologist, of course, but I'll try to get it across. I believe that an accurate histological diagnosis is very important and crucial to reduce the risk to under and over treatment our patients. And so it's very important that we had a right diagnosis between high-grade CIL or differentiated VIN. But the main problem in this topic is that inter-observant agreement with pathologists is low for high-grade CIL and is even worse for differentiated VIN, due to the simultaneous presence of other benign dermatoses, such as lichen sclerosus. So it's very important that ISSPD classification with their pathologist categorize high HPV-related squamous lesions in low and high-grade lesion. But it's also important to remember that for the case of low CIL, we don't treat because low-grade CIL is not a real precancerous lesions, and so we need to recognize, but we don't treat it. In particular, instead, for the differentiation of morphohistopathological characteristic of high-grade squamous intraepithelial lesion, we can see parakeratosis, hyperkeratosis, a particular important feature that is a loss of SER maturations, and some characteristic of nuclear atypia hyperchromasia that help the pathologist to diagnose high-grade CIL. This is the main histopathological features. But in last years, the introduction of immunochemistry helped the pathologists to better identify HPV-related lesions and the other lesions, such as differentiated VIN. For high-grade lesions, certainly P16 stain is a biomarker of any HPV lesion, and so also for vulvar lesions. And it's very important that there is a block positive strong P16 to define high-grade lesion. This is one of the most important points to differentiated high-grade lesions than differentiated VIN, because the immunochemistry now is really one of the main points to differentiate it. For differentiated VIN, is very difficult to recognize a typical morphological feature, but our pathologists try to identify the three main alterations in basal atypia that can suggest this particular rare diagnosis. First of all, nuclear atypia with some macronucleary or ungulate nucleary, that is a very pathologist features. We can't exactly explain what is it, but I think that a pathologist can do that. And so one of them is nuclear atypia associated with alterated mitosis. And also another important point is disturbance of maturation. One of the important characteristics of differentiated VIN is a premature of keratinization. And this premature keratinization is in the deeper layer of the epithelium. This is very important because we remember that the term of differentiation is not related to a better prognosis, but it's only related to an alteration of maturation of the epithelium. This is very important because the term differentiation is not a better prognosis. It's only a characteristic of histopathological tissue.
Yeah.
So,
well, differentiated can mislead someone, but we know we have to underline that is the worst type of VIN. And so we need very good pathologists, as you just told us, and experience in vulvar disease. And you have to suggest them your suspicions. Right.
yes.
May I ask you both one question? Would you consider that the staining, the P16 and P53, is now a standard of care, and we cannot accept pathology laboratories that do not use it on suspicious of VIN?
I think that now is really a standard of care for pathologists because you know that also for the different staining of P53 is not there is not there is not agreement, and so I think that it's very important that pathologists give an agreement, give some indication, and really, for example, Scary, Heller, and our pathologists did that in their last study. So I think that it's very important to use these tools nowadays. I think that it's really mandatory.
We know that probably immunohistochemistry help in agreement of pathologists, and the key value of the comparison of the reading of the slide can increase using immunohistochemistry, as was for cervical intraepithelial neoplasia in CN2 and CN3 using P16.
Yeah, well, I think that it's very important, yes.
And now for you, Eleonora, we have a strange question. What role do environmental toxins play in vulvar dysplasia? Environment.
It's really a strange question, but really there's no clear role of environmental toxin in general I think, for example, asbesto for mesothelioma, or some chemical solvents for bladder cancer, and we doesn't have the same. We don't have the same role for environmental toxin in vulvar cancer. Certainly, one of the most important risk factor for HPV precancerous lesions, for example, is smoking. And if we consider smoking as an environmental factor, it plays an excellent role in carcinogenic pathway for HPV lesions. But I think only that. We can argument about, for example, list of carcinogenic with limited evidence for skin cancer, such as petroleum or mineral oils, for example. And I think that as a gynecologist, we suggest our women to reduce or eliminate perfumes or creams or many other substances to put in our vulva, because these habits, these cosmetic habits is more common, but maybe in the future we'll discover that could be a real problem and a real risk for vulvar cancer.
Yes,
I think so. No, there is only one thing that is really the only one that I know, is that there is one study to describe that a low intake of yellow and orange vegetable could increase the risk of vulvar cancer. I don't know why there is only one study. I don't know what is the consistency, but there is that study. So you can eat more vegetable. It's everything. It's every better.
Well, you did a good bibliographic search, so we need randomized control studies. Thank you. And now for Professor Trutnovsky, Gerda, a question. The first question for you, of course, about imiquimod. How can imiquimod-based side effects can be controlled? Tell us something.
Well, with imiquimod, we know that it's a local immune modulator, and therefore we expect side effects. And side effects are actually not just a bad thing. We have to explain our patients that when they experience side effects like local redness, swelling, and they feel something's happening, that's actually good sign. So this is the first thing, just to explain them that we expect the local immune environment to work. This is how we expect the immune cells to eliminate the virus and improve the lesion. But on the other side, the local immune reaction causes side effects, and we want to control the side effects so the treatment is acceptable for the patient, because the treatment is a local treatment which takes quite some time, and we really want the patient to live with it happily. So it's very, very important to do good explanation of what's happening, and it's very important to tell them how to use it. So we always tell the patient to start in a slowly escalating regime. Start with once daily, once for the first week, just one time for 2 weeks, and then the next 2 weeks 2 times per week, and then up to 3 times per week maximum. Only if they really tolerate the treatment. If it's too much, we tell them to reduce the treatment or have a treatment-free time up to 1 or 2 weeks until the side effects go away. So that's really, really important. We also tell them to keep the cream in the refrigerator so it's nice and cool, and apply only a small amount of the cream, and really make sure they only put it on the lesion. We show them before they start treatment where the lesion is with a mirror, so they can actually apply it really on the lesion only, and do not put it over the whole vulva, which would be very, very bad thing to do. So that's very important to explain. And we tell them to do that at nighttime and leave it overnight, small with no coverage. And in the morning, they can wash it off or leave it on. And we also tell them to use some cream, some fatty cream on the other days, just to give the skin some rest and to improve if there's some irritation of the vulvar skin. So that's very important. And the other thing which worked well is that in our study, we had them for checkups. So we asked them to come in after 1 or 2 months and to check how they're doing. Because even with the best explanation, we found some people were just very enthusiastic and used a lot of cream and had lots of side effects. So it was very important to see them after a while and see how they were doing, and just reassure them if they had side effects, stop, wait till everything's good, and only restart treatment when the side effects have stopped, and tell them that less is more. So that's really important. And if this is done this way, we found that most people and most patients can tolerate the treatment with no problem.
May I ask you a question? When imiquimod was introduced, a specific side effect, the erosions, were considered to be sometimes herpetic outbreaks. So are these erosions, they can be herpetic outbreaks?
That's always something to keep in mind, that it can be just a side effect of Aldara, but you can also have infections like herpes, but also Candida infection. So that's we told them if the side effects don't stop with stop of treatment, we told them to come in and we make sure there's no other infection which could be the cause. And if you find another infection, you obviously need to treat that, stop the Aldara till everything's good, and then slowly reintroduce treatment.
Yes, it's very important to apply the cream on the lesion. So we have to teach the patient to look at their genitalia and correctly apply the cream. It's very important to reduce the side effects. Well, and sometimes the therapy is 16 weeks or long. And how long is another question. How long should treatment with imiquimod take up? To 16 weeks or longer?
Like average recommended time is 16 weeks, but we found that this really should depend on the size of the lesion. So we found that with women who had smaller lesions, very often after 1 or 2 months, the lesion had completely disappeared. So I think if we see the patient and if we see there's macroscopically there's no more evidence of lesion, I think it's fine to stop earlier. But with larger lesions, we found that sometimes it's necessary to keep on treating. Very often we found that after 16 weeks, the lesion has diminished. It's a lot smaller, but still something there. And in these patients, we continued treatment for another month or 2, and very often then we found a complete clinical and histological response. So I think if the patient's motivated and tolerates treatment, it's fine to keep on treating with Aldara until the lesion has resolved completely.
Yes, yes. Well, thank you, dear Jacob.
Okay, Elma, now it's your turn, my friend.
I'm sorry, another question. I see another question from you, Gerda. Sorry, I missed it. Can we treat differentiated VIN with Aldara, with imiquimod? I just tell that it's important to excise the lesion, but what is your thoughts about it?
It's interesting to hear both Elma and Gerda about this question.
Well,
so Gerda, you start.
Well, it's not recommended, and we actually haven't used it. So I think if it's really a differentiated VIN, we definitely should do an excision. But on the other hand, what we found, and this makes it a bit more complicated, we actually had patients who had lichen sclerosis, diagnosed lichen sclerosis, and on top of this lichen sclerosis, they developed SIL, HPV-related VIN. And in these patients, we actually did use Aldara, and this was fine. But this was quite tricky for our pathologists to actually differentiate it, and did the P16 stainment. And when we were sure that it was actually HPV related in those few patients who had lichen sclerosis plus HSIL, we used Aldara. But if it's a differentiated VIN, I wouldn't use it.
So now we turn this question to Elmar.
Yeah, the point is that differentiated VIN is usually unifocal. So I've just seen a case today, and it was a patient who already had vulvar cancer, and it's just a very nice singular lesion, which is easy to excise. And in this case, it's much more preferable to remove it. It's more safe, and then you finally have a decent histology report. But what I want to comment also what Gerda just said. So 20 years ago, we could clearly separate the older patients with lichen sclerosis and the younger with HPV-related lesions, and they have aged now. And now we see also the HPV-related lesions in the older patients mixed with lichen sclerosis. So there's certainly a change in the epidemiology.
That's a nice observation. Thank you. Elmar, let's continue with you. You are the expert on vaccines, but this time I won't ask you. The first question is not about prophylactic vaccine, but is there a therapeutic vaccine for HPV-associated high HSIL of the vulva?
Yeah, everyone dealing with VIN, and we often see these patients with really extensive lesions. We would love to have a therapeutic vaccine because we have these high recurrence rates. But unfortunately,
can you elaborate a few words about what is a therapeutic vaccine and what's the difference between a prophylactic and therapeutic vaccine?
Yes. So a therapeutic vaccine actually targets the lesion itself. It's usually based on the E6, E7 protein and blocks the oncogenesis, whereas the prophylactic vaccination, and these are the vaccines we have available, the HPV vaccines, they prevent infection, and by preventing the infection, they prevent the subsequent lesions. So coming back to the therapeutic vaccines, unfortunately, we don't have any. So I've seen over the past years a number of promising candidates. I remember a paper in the New England Journal of Medicine from a Dutch group. They even came to phase 2 in clinical trials, but finally this product never came to the market. And apparently, when you develop such a drug, it has to be effective, it has to be safe, and it also has to be cost effective. And this is probably quite difficult for the companies to develop such a thing. And on the other hand, what we've seen with the prophylactic vaccines, even you have an infection or a disease, in long term, they prevent subsequent and also recurrent disease. The first time we've seen it was at the cervix. So looking into women who underwent conization, there was about more than 60% reduction of recurrent or subsequent disease. And there's also one study done by Alessandro Geladi in Tuscany, Italy. It showed a reduction of the recurrence rate was approximately 32% in those without vaccination after treating for high-grade VIN or HSIL of the vulva, as we should say now. And in those being vaccinated, it was less than 20%. So it's not the difference not as big as at the cervix, but still meaningful for the patient.
Thank you. I think you answered the next question. Does HPV vaccination prevent recurrence of HSIL? Do you want to elaborate more on that?
Yeah, I do want. So HPV infection is always a field effect. So we don't only have the infection there where we see the disease, usually at the cervix. So we also have it in the field around, in the vulva, and a lot of infection at the anus. And what's getting more and more of interest, we probably have a sort of auto-inoculation. So when you have a productive HPV infection, then you are shedding thousands, if not millions, of new virus you're producing in your infected cells. And these newly produced virus may infect the cells around the lesion. And this is probably one of the effects using a prophylactic vaccine in those with a lesion, that you block this auto-inoculation. And it's certainly not as good as a real prophylactic use, but you certainly reduce the risk for the next couple of months and years for these patients.
So, but we must admit that there is no randomized control prospective study that proves yet that giving the vaccine will prevent recurrence. We know all that from retrospective studies, right?
It's various types of studies. So you're absolutely right. We are waiting for the results of a huge trial just ongoing in England, which is really prospective and randomized. But we have post hoc analysis of two large clinical trials, which was randomized, but the objective was different. So it's still a good quality data, and we have observational data, retrospective data, we have prospective non-randomized data. So we find all sorts of data, and looking at the full picture, it's quite consistent. So they more or less say all the same. There's only one exception of a study which was not powered to
tell the difference
for these questions in Costa Rica. And regarding conization, we have now about 500 women with conization and vaccination, and can compare these in these various studies with more than 20,000 without vaccination. So it's robust, but we are still waiting for the final answer. And looking at the vulva, it's even more difficult to run a trial for the effect in women treated for HSIL of the vulva and being vaccinated. So there are plans in the Netherlands to start such a study, but when you do your calculations, it's pretty difficult because it's a rare disease, and will probably in the near future rely on the cervical data and apply this to the vulva and the anus.
Thank you very much. So you would say that, let me bother you again with that. For conization, for CIN3, most of us, I think, will recommend vaccination if that patient has not been vaccinated at the time or even before the conization. For vulva, for HSIL, you say, I will recommend as well. Would you say that this is a standard of care now? Would you say that this should be given?
Well, we haven't reached the point where it's standard of care. So I personally believe in this and I recommend it. But if I would be the paying body, I still might be cautious. And we exactly have this situation in Austria. So it's now paid since 2 years for women undergoing conization up to the age of 45, but it's still not paid for vulvar disease. But usually when you make an application, they are quite generous and they approve it, but it's not standard yet.
Very good. I think we clear this issue. Mario, it's your turn.
Well, now to Eleonora again. We know that in the European Institute of Oncology of Milan, we have a lot of experience about laser therapy. And what about the management of precancerous disease of the vulva with CO2 laser?
Thank you, Mario, for this question. You know that I'm passionate about the laser and the use about these tools in every single gynecological areas. If we consider the literature, we consider that we have few studies about the use of laser on vulvar diseases in general. We have a Cochrane review in 2016 that demonstrated that we have no best treatment for vulvar disease, in particular for high seal. But certainly in this review, you can consider the use of laser only for ablation or vaporization. But really, we can use these tools also in the way of excision. And so this is very important for example, differentiated VIN. We can use laser for ablation, of course, but we can use laser for excisional treatment. And in this way, we can consider laser really a good tool to treat vulvar precancerous lesions. With laser, under colposcopic guidance and with a micromanipulator, we can exactly identify the first surgical plans described by Reed in 1985 on the vulva. And this is very important because we can see every single plan and you can excision them by one. And this is a very good result, and it's a very good goal for laser. And we don't do with a knife under vision. We can do only with magnification, so only with the colposcopic guidance. I remember you that these 4 surgical plans are different and depending on age of patients, vulvar areas that we consider, for example, airy or not airy. We are close to clitoris or urethra or vestibule. And this is a very important point to reduce the damage of laser and surgical treatment, but without reduce the oncological outcome of the patients. There is a recent Italian study that describe exactly laser treatment for a high-grade C, for example. And in this study, we can see that also positive margins is not considered a risk factor of recurrence. For many reasons, but in particular because that treatment is under colposcopic control and with a team of experts with a great experience in the vulvar area. And so this combination is really an optimal combination to treatment patient with laser. Nowadays, we are assisting to an increase of use of laser for regenerative technique, for atrophy or for genitourinary syndrome. But we need a learning curve, a very important training to use laser for excision and for treatment of for vulvar diseases. Is not the same. Is not the same technician to use laser for regenerative intent or for treatment intent. It's completely different. This is very important to remember.
It's important also to remember that our society has a statement about regenerative use of laser not approved by the FDA and so on. So we need the caution until a large randomized controlled studies approve the use of laser for other than excision. But well, excision is very important. I think that the use of colposcope is of utmost importance to better excise the lesion and respect the surgical plane and to avoid the scare in the follow-up of the patient. And the last question for you.
Let me Mario, just give acknowledgement to Eleonora, who remember Richard Reed planes on the skin. I attended one of the original seminars by Richard Reed, and
it's fantastic. I don't know.
So I acknowledge that.
And you remember, dear Jacob, that our grandfather of the society, Ed Wilkins, wrote a paper about the presence of follicular in the depth of the skin, so 2 millimeter and 5 millimeter around the hair bearing and not hair bearing skin. Very good paper on obstetrics.
That issue was the paper who introduced me to this society, the combination therapy of excision in hairy skin and laser in non-hairy skin, because in non-hairy skin you can do it superficially.
Right.
Yes, because the thickness is less than 1 millimeter to 4 millimeter, and so only with magnification is possible to see that thickness. I really believe in the use of laser in these cases. And we use in combination, of course, sometimes with excisional surgery and then with laser.
And our pathology is used to say us, remember that your eyes are not a microscope, so use the colposcope. Well, Eleonora, we would like to hear a discussion about laser treatment, Langer surveillance, and anal cancer screening in patient affected from vulvar intraepithelial neoplasia, because we know that these patients are at a higher risk for anal intraepithelial neoplasia too.
Many questions, few words to answer really, because we know that patients with HPV lesions on vulva or in vagina are at high risk to develop another HPV lesion in all genital area, such as the anus, for example. There's some recommendation of CDC or endoscopic or American endoscopic to recommend anal cancer screening in particular population, such as immunosuppression patients, but also women with HPV lesion in vulva, vagina, or in cervix. It's the same because they are patients at risk to develop another lesions, and also obviously in men, sex men. This is the main risk population to suggest a screening, an anal screening. It's important to remember that anal screening is based on high-resolution anoscopy associated with the pap smear, but HPV test is not validated for anal area, and so we can do it now. It's not a screening test. We can use only in experimental or in protocol, but not as a screening. In relation, instead of length of surveillance, all patients with a vulvar precancerous lesion, high related or differentiated via IAN, is a risk for long life, and so we need follow-up for lifelong, forever. There is no standard of follow-up time frame, but the ISSVD also suggests monitoring visit every 3-6 months, depend of the age of patients, type of lesions, symptom control, but 3 to 6 months, it's a good follow-up. I think that it's also important to educate our women to self-examination, so to prompt early visits if in case of symptoms, in particular uncontrolled symptoms, or in case of the appearance of the new lesion. So I think this is the two more important points: regular follow-up and self-education for the women.
Elmar, raise a hand and please that's a word.
We can hear.
You are muted, Elmar.
I want to put the focus on those being diagnosed with HPV-16, because all lesions outside the cervix are almost exclusively based on HPV-16. And so when you have a patient with a conization and HPV-16, she's at risk for developing lesions at the vulva and at the anus. And again, at the vulva, you almost all the time have HPV-16, and they have an enormous risk for developing anal cancer in the future. So once you have identified HPV-16, take care.
Yeah, I think at this topic, we have a final question for Gerda. There's multifocal disease in patients with immunosuppressive therapy, like a renal transplant patient for arthritis and some other issue about immunodepression.
Well, patients with immunosuppression, we know that they have a definitely increased risk of HPV-related disease and an increased risk of recurrence if they have this. And just as like we have heard before, especially in these patients, it's very important to have regular follow-up visits, because we know that they are very likely, even if they are treated, to have recurrences, and not only of the vulva, but of the vagina, cervix, and anus. And this is the same in all immune suppressed patients. This may be medications with autoimmune disease, but also we know that in HIV positive patients with AIDS, that they have an increased risk of recurrence and quite fast recurrence of HPV-related disease. So it's very important for these patients to have the regular checkups. But also, if we start immune suppression because of transplantation, let's say renal transplantation, so it would be very important to do an HPV vaccinations early on, when the immune system is still working. To do it before there's immune suppression, if possible, it would be good to do the HPV vaccination early on. And for treatment, it's hard to tell because well, we obviously have the surgery as treatment options. With imiquimod, it's less clear, because imiquimod, as we talked before, it depends on the local immune system. There's quite some evidence that you need local immune environment needs to be sufficient for the response. But then on the other hand, we do have those recurrences. So if we do one surgery after the other, that's not a good thing as well. So there are quite a few publications that in patients with immunosuppressions, patients with HIV, with anal disease, imiquimod is quite a good option as well. So they use surgery, imiquimod. I think in those patients, really, you just need to keep treating and make sure you don't miss the invasion.
Yes, thanks. Very clear.
Elmar, now I have a question to you. We concentrated today on vulvar disease, but you know, there's a growing incidence of other and HPV-16/18 associated cervical and vulvar precancerous disease. And also, I would like you to comment about the disease of the oropharyngeal area.
Yes, there is always the discussion about replacement, that some strains might use the niche when you eliminate other types by vaccination. But so far, we don't have any evidence for this. So in general, we also see a reduction of most of the other types, and it's a statistic law. If you test for 30 parameters, you always have some values which present unexpected results, but this is not consistent. Just recently, there was were data published from Finland, from a very important cohort study, which clearly showed that gender-neutral vaccination is highly effective, but what they observed, a relative increase in HPV-52 lesions and also HPV-66. But the good news is this was a single type, and HPV 52 will be eliminated with the 9-valent vaccine, and I've never ever seen any lesion with HPV 66. So I think we are quite on the safe side. And the oropharynx is getting more and more important. So we already have more cases of men with HPV 16 positive tumors in their throat than we see women with invasive cervical cancer in the Western world, in countries where we have screening. But again, what I've said before, this is almost exclusively related to HPV 16, and I'm not aware that there are other types playing a role. So there's a good point that we should not only vaccinate women and girls, it's as important for boys and young men. And I think the prevention of oropharyngeal cancer is a good reason for boys and young men to be vaccinated.
This is very important. By the way, regarding HPV 66, I did see it in smears, but I think it is very low risk, or it's the lowest of the high risk, maybe borderline with low risk. So I don't think that makes any threat to us.
Yeah, so in real life, you always see the lesions with the usual suspects. So you hardly ever have any surprise. So we're already surprised when we see an invasive cancer with HPV 31. And this, for instance, produces a lot of CN3, but only rarely cancer. But all the other types we simply don't see in real life. So when you look at thousands of cases of cervical cancer in the statistics, those cases pop up, but in our clinicians' life, we don't see them.
Very good point. Mario, we are approaching the end of the hour. Would you talk a little bit about what you preach lately, the prevention of vulvar cancer by self-awareness?
Yes, you know, dear Jacob, that in 2018, the ISVD promoted the Vulvar Awareness Day. We started with the prevention of vulvar cancer, and then lichen sclerosus, then vulvodynia, then vaginitis. We need awareness of the patient, and one on the main aim of the society is to promote awareness among the patient. And so in this afternoon, of course, express our gratitude to our panelists. Thank you so much, dear friend, for being with us in this afternoon. And for the audience, we are more than 250 attendees, so thank you so much. And those who have submitted question during the session, and don't forget our ESVD. Please remember to visit our website and consider, as Professor Jacob Bornstein told you at the beginning of the session, to join us in the upcoming World Congress in Slovenia. And you can download our guideline on vaginitis, are free from the website. And if you have any question, please mail us at isvd@isvd.org. Thank you again, and I let you, Jacob, and your friend, our friend, the last words. Thank you.
Well, thank you very much, Mario. I think I enjoyed this session very much. I learned a lot, as always. Thank you very much, Mario. You've been a great co-host. And thank you, everybody, and have a good evening. Goodbye.